Hello, everyone. Welcome to the UNC Core Center for Clinical Research 101 Introductory Series for July 29th, 2020. We appreciate you joining us for today's talk. Our presenter today is Dr. Amanda Nelson, an Associate Professor of Medicine in the Division of Rheumatology, Allergy, and Immunology at UNC Chapel Hill. Her presentation today is titled Arthritis 101. Dr. Nelson, whenever you're ready to begin, please feel free.
Great. Well, good morning, everyone. I think a lot of you are repeat consumers of this, but I know we have a couple of med students, a couple of new people. So this is essentially an overview of kinds of arthritis and differences between kinds of arthritis and things that you might hear the clinicians and researchers at TARC talking about. So it's sort of an orientation overview. So certainly if you've heard it a million times, feel free to do something else. But I think that it gives a good sort of place for where things fit for people who might be new to this field. So we're going to talk a little bit about terminology, which trips up even residents and fellows sometimes, so we'll review some of that. And then we'll talk about a few common types of arthritis that you might encounter in your work or discussions with researchers or clinicians, specifically osteoarthritis, rheumatoid arthritis, some of the spondyloarthropathies, and gout. So terminology, we talk a lot about joints, and sometimes we forget to explain what we're talking about. So there are different joints in the hand that we often call DIPs and PIPs, and you're not sure what we're talking about when we do that. Normally at this point I hold my hand up and show you, but I have a picture later. Essentially the DIPs are the little joints out by the fingers, the PIPs are in the middle, and the MCPs are the joint at the finger and hand. CMC is the base of the thumb, and then MTPs are the joints in the toes. And so when we sort of shorthand those, you'll have an idea. Synovium is the lining of a joint, so it's a very thin tissue that I'll show you a picture of later. And itis is inflammation. So synovitis just means inflammation of the synovium. It's very simple, but sometimes we throw that word around and don't really think about it. And similarly, arthritis is inflammation of the joint itself, regardless of where in the joint the inflammation is. Monoarthritis is inflammation involving one joint. Oligoarthritis is a few joints, up to 4, and polyarthritis is more joints than 4. Arthralgia is pain in a joint where we don't feel inflammation. So whether that's clinically or we have imaging or whatever it might be, the joint hurts, but we don't see any evidence to support that it's arthritis, that there's inflammation in the joint. I'm stuck. Here we go. So osteoarthritis, in the past, hopefully very distant past, although I think this is still around, was termed a wear and tear degradation of cartilage, or the dreaded degenerative joint disease. Please don't say that around TARC. We all get very upset about it. It's oversimplified, and it doesn't cover the complexity of the disease. So this is the new ORSI definition. It's a little clunky, but it gets at the key point. So osteoarthritis involves movable joints. It involves cell stress and matrix degradation that are both micro and macro. So they're on a microscopic level and also that you can see, like with arthroscopy. That then activates a maladaptive repair response. It causes inflammation, activates immune pathways, and it can manifest first as a molecular process that we can't see, for example, on imaging, and then is followed by anatomic and physiologic derangements, including cartilage degradation, bone remodeling, osteophyte or bone spur formation, joint inflammation, and loss of normal joint function. So it's really a disease of the entire joint that affects all of the tissues on a molecular and an anatomic basis. So it's much more complex than degenerative joint disease. The symptoms and signs of osteoarthritis, I think we're all pretty familiar with. So you get pain that's related to use. The more you use the joints, the worse they hurt. Patients often describe pain that is worse at the end of the day and over the course of the day. They generally have minimal morning stiffness, so less than 20 or 30 minutes. And then if a person sits for a while, they get a phenomenon called gelling, which is sort of a recurrence of stiffness. Decrease in range of motion is very common. Sometimes the joints are unstable or they feel like they're going to give way. There can be bony enlargement, which again is these bone spurs and changes in the shape of the joint. restricted movement. Crepitus is that sort of popcorn crunchy sound you get when you go up and down stairs. Pretty much all of us if we're over 20. There's some swelling and instability that can come along with it. There are a lot of risk factors for osteoarthritis, many of which are unfortunately not modifiable, things like age. We're more likely to get OA as we get older. Women are more likely than men, at least at some joints. Obesity increases our risk for developing OA. If our knee is malaligned or shaped a certain way that predisposes it to biomechanical stress, that can cause osteoarthritis over time. Genetics and heredity. A lot of times patients will say, well, my mom's hands looks just like this, you know, as she got older, and they start to develop nodular changes that we'll talk about. Trauma, joint injury can predispose to development of osteoarthritis. There are kinds of neuromuscular dysfunction and metabolic conditions that can also contribute. So here's a picture I was mentioning earlier. So let me, one second, I'm just pulling out my pointer. Here it is. So DIPs are these joints out here. This is a PIP. This is an MCP. The CMC is down here. And so here we're looking at these hard bony enlargements. You can almost see that they're hard. They look shiny and not like they would be squishy if you touched them. You'll see another picture that's very different from this later. So this is a Heberden's node, which is at the DIP joint, and that's a very common characteristic of osteoarthritis, particularly hereditary types of OA. A Bouchard's node is the same kind of enlargement at the PIP joint. And the CMC joint can start to look kind of squared off. So instead of being round and sort of the usual shape, it gets kind of squared, and it's related to changes in the joint space itself, which I think I have a picture of. So this is a normal hand. Another thing we often forget to do is orient learners to what normal looks like. So this is just a hand joint, hand x-ray held up. So again, MCPs here, PIPs, DIPs up here, the CMC joint is right here, the wrist is here. And so you can kind of appreciate that the joint spaces are pretty uniform throughout. Everything's sort of lined up in straight lines, all the rays are straight, and it's all pretty regular. And if we contrast that to an osteoarthritis x-ray, we can see a bunch of things. But to note, there is sclerosis and narrowing of the CMC joint, which is kind of taken on that squared shape. We can see loss of joint space and overgrowth, these bony enlargements at this PIP joint, big osteophytes, and really there are osteophytes all through here, collapse of this joint as well. This is also osteopenic, which means that the bone density is reduced compared to the normal. Same thing for knees. So here's a normal knee, nice and straight. You could draw a line right through there. You can see an even, nice thick space between the femur and the tibia here. All looks pretty nice. And if we look at an osteoarthritic knee, we see that the medial joint space here is essentially completely collapsed. There's no space. There's osteophytes, so all these extra bony things sticking out over here. There's a cyst or geode up here. There's increased density here, which is bony sclerosis. It's malaligned, so we see that it's sort of angled instead of being straight, which is a varus malalignment, which is also very common. We can also see osteoarthritis in ultrasound, and many of you know I have some research interest in this as well. And these are some pictures from our study that show that osteoarthritis is much more inflammatory than we often think of. There are large effusions in many cases. There's a bone spur here on the patella. This is sort of across the top of the knee, so we can see the femur down below. This is with the knee bent, so we see the femur bone coming across here. The cartilage is this black layer here. And so we see that although there's cartilage on this side, when we get over here, there's really no cartilage left. We can see the meniscus, so this is at the joint line, this is the femur and the tibia. The meniscus is sticking out, so meniscal extrusion and degradation are also very common with osteoarthritis and with aging in general. We can see these large osteophytes. This should kind of come smoothly to an end, and it's big and bulbous here. And there's also some fluid surrounding it. This is at the back of the knee. So here we see the femur and the calf muscle, and we can see this large fluid-filled space. This is a popliteal cyst or Baker's cyst, which is also common, not specific to OA, but common in OA. When we think about types of arthritis, sometimes we talk about distribution. So we think about which joints are involved, how are they involved, how does that pattern fit with the kind of arthritis we might be thinking about. So osteoarthritis typically involves the large weight-bearing joints, so hip, knee, both patellofemoral and tibiofemoral, the big toe, the DIP and PIP joints we just talked about, the thumb, the spine, the AC joint and SC joint here, not really the shoulder joint itself. And you see a lot of the other joints are not shaded. And I'll contrast this to a different kind of arthritis in a little bit. So pattern can be important. And once we think someone has OA, how do we manage that? Well, first we have to figure out they have it and explain it to the patient and how it differs from some of the other things we're going to talk about. We want to decrease their pain to improve their function. Exercise is really a key intervention. I'll show you that again in a minute. Really improves function, increases strength, reduces pain, reduces fall risk. It does everything we want it to do to improve osteoarthritis function. And weight loss is very important for people who are overweight. And I mentioned education. This is a little bit old, but it's still a nice visual. This is the ORCE guidelines from 2014. They've recently updated these. But you can see that really for all patients with OA, we're thinking about exercise and weight management and strength and education. And it doesn't matter how their OA sort of plays out or which joints are involved. When we think about specific interventions is when we start to consider which joints, what other comorbidities a patient has, et cetera. But the core treatments hold across, and that has not changed in the new guidelines. These are the new American College of Rheumatology guidelines. And so same kind of idea. Here we're looking at the physical, psychosocial, and mind-body things, so the non-pharmacologic approaches, pharmacologic over here, hand, knee, and hip across the top. And these are just the strongly or conditionally recommended interventions. And you can see again that exercise is really recommended across the spectrum, regardless of anything else that's going on, because it's very beneficial. Self-efficacy and self-management don't have a huge effect, but there's certainly a positive effect with no risk. Weight loss, I mentioned, also Tai Chi, cane use when needed, or other walking aids, certain types of braces. These are all things that have become more recommended over time. Things like heat and ice, other sort of symptomatic management strategies that have increasing levels of evidence. There's a lot more over here than there is over here. We don't have great pharmacologic management for osteoarthritis. We don't have anything that stops the progression or prevents the process. So these things are more directed towards controlling the symptoms and allowing continued function and participation in activity. So things like non-steroidal anti-inflammatories, whether oral or topical, intra-articular injections. Acetaminophen has fallen a little bit out of favor. Its effect size seems smaller and smaller the more studies we do, and the risk actually seems to be going up a little. So it's useful in some patients. Sometimes it completely controls symptoms and it's low risk at low doses, but it's just not the first line, everyone should be on it kind of treatment that we used to recommend. And you see a few of the others here. So we're going to move on to rheumatoid arthritis so that I can contrast some of that with what we just saw about osteoarthritis. So it is a systemic inflammatory disease. It's autoimmune. It can be very debilitating, so can osteoarthritis. There's certainly increased mortality and disability related to this, although that's improving with our better therapies. And it affects about 1% of the population worldwide. So here's a picture of RA hands. And so if you think back to our picture of OA hands a minute ago, the first thing you'll probably notice is this sort of soft tissue swelling all the way across the MCPs. It's very symmetric. So this is synovitis of the MCP joints. It's symmetrical. It's in the small joints of both hands, a little bit different than what we saw with the osteoarthritis. RA typically does not really affect the DIP joints that much. It can certainly get at the PIP joints, and it's less interested in the CMC. So the distribution is different. We can see subluxation, so how these joints are sort of fallen down. It looks like these are on the table and this is sticking up, which is pretty common. Synovitis of the wrist, you can't quite pick up. And some of these deformities here that how the fingers are held is not how they're holding their hand, but rather how they're stuck holding their hands. So changes that are not reducible. And so we also see the same kinds of changes in this one. And here we're seeing ulnar deviation. So the whole hand is sort of shifted over toward the ulnar side of the wrist, which is the side the pinky finger's on. And this can be, in early stages, still reducible, meaning we can put the hand back straight. And in later stages can get stuck this way, in which case it's non-reducible. When the ACR put out that this was taken from an ACR slide set a while ago. This was called an across-the-room diagnosis. So if you could see that, you should be able to say that person has RA. You can see that. You can start to see like this PIP is swollen, these MCPs. This one's a little bit asymmetrical, which is not the norm, but certainly a possible pattern. This is the same hand flipped over so that I can show you a similar X-ray. So if you saw this hand, how the X-ray might look is that those joints are sublux, meaning they're not aligned and they're sort of overlapping. This one's really not connected anymore. It's very osteopenic. There's a loss of, lost my mouse connection, loss of bone density. And there's sort of, sorry, my pointer died. A loss of joint space in several areas as well. You really can't see the wrist, particularly mostly because it's fused and degraded there from long-standing inflammation. You can get, there we're back, deformities of the joints, again, that have, my pointer is just not going to work. So you can get swan neck and boutonniere deformities. So the boutonniere is at the pinky finger, where it's sort of bent at the PIP and extended at the DIP, and then the swan neck is the opposite, which you can see in the ring finger on that hand. Those are typically late stage findings that are after many years of disease and much damage to the joints. And again, clue you into the diagnosis pretty early. These are the 2010 criteria for rheumatoid arthritis, not to memorize them, but rather to think about the differences between RA and OA. So first, the patient has to have synovitis. Well, they probably didn't have clinically apparent synovitis in your OA patient. So they have a joint that has unexplained synovitis. You don't have another reason for it. You get more points for having more small joints. So like we just talked about, it often involves both hands, lots of different joints across both hands. So if you've got more than 10 joints, you get 5 points. You've almost got the diagnosis already. If you just have one knee, you get no points because that's probably not rheumatoid arthritis. It could be, but it's probably not. Then serology is important here, which is not an important part of osteoarthritis, in that they have rheumatoid factor and anti-citrullonated peptide antibodies and other blood markers that can clue you into the diagnosis of rheumatoid arthritis. They often have elevated inflammatory markers, much more than osteoarthritis patients, and typically have symptoms for more than 6 weeks. And so adding up points, if they have 6 or more, they get classified as definite RA, but really just to contrast the two conditions. And then I mentioned pattern of disease earlier, and so we saw the half of the OA picture already. And so if we look on the right side of the screen at the RA picture, we see that it adds glenohumeral joint, it adds elbow joint, we see the wrist, and a lot of different little joints in the feet. So it's really potentially affects a lot more joints, often again in a symmetric pattern, and which joints are more common is different between the two. There are some other features that can clue you into rheumatoid arthritis. So nodule development, so not these hard bony nodules, but little squishy nodules that can develop over pressure points and extensor surfaces. So there's one at the elbow. Rheumatoid factor, I mentioned, is pretty common. It's not specific to disease. ACPA antibodies are more specific, but these are all sort of clues that maybe there's something else going on, more inflammatory. They can develop marginal erosions, which I'll show in a minute, and much more dramatic synovitis than what we typically see in osteoarthritis. You can see it in both, but the extent of it is more in RA. And so here's a marginal erosion. So there's sort of this little hole in the bone there that should be a nice, smooth, well-corticated surface. I mentioned earlier that synovium is a thin, delicate tissue, so this is sort of the single layer lace-like synovium that you should see in a normal joint. As we get into very inflamed synovium in a rheumatoid arthritis patient, you can see lots and lots of cells, and that whole layer is just much more thick. There's a lot of extra stuff in there that shouldn't be there. And that stuff can then erode into the bone, which is what causes the erosion. So this sort of solid light pink at the bottom of this image is bone, and all the pink spotted stuff at the top is the tissue with all the extra cells and inflammatory features drilling down into that bone. And that's what we call pannus, and results in erosions in RA. So damage can occur early. Again, that we don't see the natural history that much anymore, thank goodness, because we have really nice treatment. But we still get patients that were not treated or didn't have available treatments, didn't have medical care, what have you, and really have a lot of damage. And it in those cases can cause early mortality. Mortality in RA these days is much more related to cardiovascular disease or drug side effects. And these figures are older, but just to emphasize that it's a systemic disease. It causes systemic inflammation and then contributes to a lot of these other potentially morbid conditions. It's just another picture of RA. Again, education is really important. I think that's true for all of these, but for the patient to really understand, because terms like rheumatoid and rheumatism and arthritis and all kinds of other interesting things that patients come up with, they don't know what those mean, and they don't understand the prognosis of their condition or what treatment options make sense for them versus their friend who has arthritis. And so education about what particular condition they have and what they can expect from it. Exercise is important again. Exercise is going to be important for all of these. So maintaining range of motion and strength can really help. And then there are a lot of medication options for rheumatoid arthritis in particular that I'll run through. So NSAIDs are still good, certainly for flares of disease or very early disease or different situations. We try to avoid prednisone, but low doses of prednisone can be extremely useful in certain circumstances. Intra-articular steroids work for RA as well as OA, especially if there's a single joint or a couple of joints that are really problematic. And then we have disease-modifying therapy for rheumatoid arthritis, which is really nice. We don't have that for OA. We have sort of traditional drugs like sulfasalazine and Plaquenil, which we hear more about these days than we care to, methotrexate, and so on. And then we have a lot of biologic agents. And so anti-TNF therapy has really changed the game in rheumatoid arthritis, but it doesn't work for everyone. And so we have B-cell targeted agents. We have co-stimulatory agents that target the interaction between B and T cells. We have agents against other inflammatory pathways, so not just TNF, but also IL-6 and JAK inhibitors. There are others always coming out. So we have a lot of choices in rheumatoid arthritis. What we don't have is a test to say which thing we should use. Everyone's been working on that for a while. So we end up kind of working through several agents until we find something that works, but at least we have a lot of choices. And so just remembering that find these folks, diagnose them, treat them early, really make a huge difference with aggressive treatment that controls their inflammation, both for their RA, but also for the extra-articular manifestations and their cardiovascular disease and all the other things that come along with having a systemic inflammatory disorder. We want to continue to assess and monitor the severity of their disease over time and continue to adjust their treatment, particularly as it relates to drug toxicity and a lot of things that can happen with all of the drug choices that we have. I don't have a good spot for this, so I just put it in here, but there's another entity called Jacquard's arthropathy, which really happens in patients with lupus. But if you look at picture A and don't, just kind of glance at it, you might think that that person has RA. They have a lot of the deformities that I was just talking about. But in Jacquard's, they're completely reducible. So if you took that patient's hand and sort of gently flattened it back out, it would go completely flat, and you could make an x-ray that looked perfect of that if you wanted to. It's typically non-erosive. It can be painful. It's not always. Some patients walk around with hands that look like this and they're fine and they're perfectly functional. So it's just nice to be aware that this is another process that can happen. Certainly lupus patients can get erosive arthritis. They can get fixed deformity, but just this particular entity is something to be aware of. All right, so now we're going to move to the spondyloarthropathies, or seronegative spondyloarthritis. So there are several types of this. The categories kind of shift around, but the general idea is the same. So we'll talk about ankylosing spondylitis and a couple of others here. So common features, regardless of how you think about this, is axial skeleton involvement. A lot of these folks get sacroiliitis. What's that? So that's inflammation of the joint between the pelvis and the spine in the back. I'll show you a picture of it in a little bit. But a lot of times they'll describe low back pain, buttock pain, alternating buttock pain, something kind of back at their lower spine, often with a lot of stiffness, that can really differentiate these folks, because that's not a typical finding in either OA or RA. They can have peripheral joint involvement. It can be prominently that, but the axial piece is a little bit different. It's also a systemic inflammatory disease. So not only do they have joint involvement, but there might be inflammatory eye disease. So things like uveitis, which is a very painful condition that can cause vision loss. They can have enthesopathy, which is inflammation where things attach to bone. So tendons and ligaments and things attach in, and there's a sort of an enthesal organ there where for example, your Achilles tendon comes back and attaches onto your heel bone, and that's an enthesis that can become very inflamed in these conditions called enthesitis. A lot of patients that have these disorders are positive for HLA-B27, which is a genetic marker, not all. Often happens, particularly AS, which is the sort of prototype of these, in young adults, so in ages 20 to 30. So they're sort of a different demographic than the regular sort of low back pain patients, because low back pain is obviously extremely common. Mechanical back pain, much more common than AS. But if it's a 20-year-old who's saying that their back is so stiff they can't work, and they get up in the morning and they're stiff for 3 hours and they have to go exercise in order to move, that's a very different story than you get from a typical mechanical back pain. Much more common in men, more common in Caucasians than other ethnic groups. And this inflammatory back pain that I was mentioning is very stiff. So sometimes patients will get up in the middle of the night and walk around just because they're so stiff that they can't sleep. Or they might get up and the first thing they do is go take a 2-mile walk. Well, a mechanical back pain patient probably is not doing that. So that sort of dramatic improvement with activity, often they won't sit down, because as soon as they sit down, they get incredibly stiff again. So they're just sort of constantly in motion, constantly trying to address this inflammatory back pain, and typically feel better at the end of the day because they've been up and moving around rather than worse from that. Pain and stiffness we'll talk about at the SI joints. There are some clinical measures of reduced range of motion, again, mostly getting at the axial involvement, so you can assess how far forward they can bend, how far their chest will expand at the costochondral joints, whether they can put the back of their head against the wall like you do when you're a kid, getting your height measured, all of those things kind of getting at the mobility in the axial spine. So again, sorry, my pointer has completely given up on me here, but the SI joints are the straight lines up and down on the sides. And you can see a space there. So right in the center is the sacrum, so that's the very end of the spine. Out to the sides are the hip joints at the bottom corners. And so the SI joints are running vertically there. And on this picture, you can't see them because they are no longer there. And so we've gone from having some inflammation on the left side of the screen where that SI joint is sort of whiter than the other one and irregular, to complete fusion. And sometimes when people completely fuse their SI joints, their pain actually resolves, or at least improves, because they don't have that sort of constant source of inflammation back there. But they often have involvement in other places, so it doesn't mean they don't need to be treated. But we do occasionally run across a person who's just fused and now feels okay. In the spine, we see something similar. So these are normal, in case you're wondering. So you see spaces between the vertebral bodies, everything's sort of curved. There's a usual lordotic curve in the spine, you're probably aware, it kind of looks like that. And so you want those nice even spaces, everything's lined up where you want it, and the spine's straight in the front. As you develop syndesmophytes, which are these tiny bridging form of osteophytes. So we talked about osteophytes in OA, which are big bulky bone spurs. Here we're talking about sort of bone lining along the front of the spine. And so we start to get a straightening, so that curve is sort of gone, and really the spaces are gone. They're sort of connected now where they weren't before. So if I go back, there's no connection between the vertebral bodies here, but here there is a little bit on the left and very much so on the right, which is what we call bamboo spine, when it starts to become sort of a solid object and over completely ossified. And this one's just another even further example. This is a obviously extremely old picture, but it demonstrates it very nicely. Fortunately, we can usually avoid this now, but the progression over time used to be unavoidable. And so the goal was to fuse in a functional position, to fuse face up, as you can see on the far right, so that you can still eat and talk and interact with people, because if you fuse face down, you're sort of isolated from the world, and there's really not a whole lot to be done about it at that point. And so physical therapy and occupational therapy and those kinds of things were really what we had. Fortunately, that has changed quite a bit, although those are still key aspects to the management. We now have many additional therapies that can improve the outcome for these patients, which is really important, because you can imagine if people were getting this in their 20s and fusing over a period of 10 years, that's not a great prognosis. So NSAIDs work great for this. They're actually the first line therapy in all the guidelines, but they're often not enough. And so we think about DMARDs. Sulfasalazine and methotrexate really don't work for axial disease, but if people have particular peripheral disease, they can be useful adjuncts. But really, we go pretty quickly from NSAIDs to TNF inhibitors for patients with AS now, and sometimes into IL-17, which is a new mechanism that we have available for these folks. So able to treat them much better and much more satisfactorily than we were in the past. So psoriatic arthritis can be very similar. It can look very much like AS, or it can present much more like rheumatoid arthritis as an inflammatory polyarthropathy. You think, well, it's psoriatic arthritis, so I'll know they have it. Well, unfortunately, you can get the arthritis before the skin disease shows up. So sometimes I've had patients show up with just one big swollen finger, and I was like, well, that's going to be something. I'm not sure what. And then 2 years later, they come back with their psoriasis. We send them to dermatology and make that diagnosis, but they don't always come in the order that would help you to make the diagnoses. Again, typically seronegative, the sex distribution is more equal for psoriatic arthritis. It's not as common as rheumatoid. And it can, again, be symmetric or asymmetric, and be axial. It sort of can present in a lot of different ways, so you have to keep a high index of suspicion. Psoriatic arthritis then likes to involve the DIP joints. So we talked about OA involving the DIPs, and that RA really didn't, and now we're back to DIP inflammation. So if somebody has a big, hot, swollen DIP joint, you're sort of wondering if they might have psoriatic arthritis, or maybe erosive OA, or maybe a crystal disease, probably not immediately thinking about rheumatoid arthritis. They can get sausage fingers, so the right index finger there, the whole finger looks kind of swollen, even down into the hand a little bit, called dactylitis. They can get nail changes, which are present here. It's a little hard to see. I have a better picture later. And sometimes they'll get nail changes at the DIP joint that's affected, so that can kind of include in sometimes. Obviously, if they have skin psoriasis, and looking for skin psoriasis is important. So you look behind the ears, you look in the ears, look in the scalp, look in the gluteal cleft. There's lots of places that psoriasis can hide that patients might not even be really aware of. And again, they don't happen in order, so you might have the arthritis first. So these are some better pictures of dactylitis. Obviously, there's some nail changes and skin changes here as well. So these are called sausage digits. And I don't ask patients if they've had dactylitis. I ask them if they have a finger or a toe that swole up like a hot dog, and often they can recall that. This will be fine. And psoriatic arthritis and reactive arthritis, which I'll mention in a minute, are the typical causes of dactylitis. So if that whole joint, whole ray is really swollen, then you're thinking more in these categories rather than something like RA. Here's another one, a big swollen DIP, but kind of extending down. The radiographic changes can be pretty remarkable. So in A, we're seeing sort of this fuzzy new bone growth. Like if you tried to draw a line around all of those bones, you'd have a hard time because they're kind of hazy. It's like, well, where is the cortex? And that productive new bone growth is a clue on x-ray that one of these kinds of conditions may be happening. And then over time, you can see something called pencil and cup, which is shown in C, where the end of the phalanx just really becomes eroded and pointy and sort of unstable inside the end of the next joint. And this is a picture of arthritis mutilans, another form of psoriatic arthritis, where the joints are really destroyed. And the bone density is pretty normal. There aren't a lot of features of some of the other kinds of arthritis we talked about, but there's just all these really severe deformities and loss of function in these hands. Some of the nail changes here, so there's kind of this scooping and the little pits that look like a golf ball, again, often at an affected DIP or an affected finger, can be a clue. Even if they don't have psoriasis elsewhere, they can have psoriatic nail disease. Again, NSAIDs are useful, steroids are less so, but we fairly quickly move into TNFs or other cytokine inhibiting drugs. Methotrexate can be useful as an adjunct in particular, so sometimes having methotrexate and an anti-TNF like we do in RA can be very helpful, particularly for the peripheral joint involvement and also for the skin disease in a lot of cases. All right, so moving on to crystals. So gout is sort of the prototypical crystal arthritis. The prevalence of gout is on the rise. I didn't go and update my slide, but I know there have been several recent epidemiologic studies that sort of show this increase in prevalence over time. And here we're talking about a different pathway. So this isn't autoimmune, this isn't degradation of the cartilage, this is a deposition of a crystal that then initiates this inflammatory cascade. And so hyperuricemia then causes supersaturation, so there's too much uric acid. That uric acid then crystallizes inside the joint tissues and initiates this really dramatic inflammatory response. And a lot of times, this, like in textbooks, we'll describe as the worst arthritis because it's just so incredibly inflamed and hot and red and swollen, and you can barely touch it. People don't want to have their bed sheets on their toe. It's often in the great toe. So incredibly painful, very inflammatory process. Also can have some extra-articular clues. So tophi are little depositions of uric acid in other places, not just in the joint. So the ear is a place to look, these little white chalky deposits. Sometimes you can see those around joints in the hand. Big tophi at the elbow are reasonably common. If there's one in the elbow like that, you can actually aspirate fluid from that to look for the crystals rather than having to get it from a joint. I'll show you a picture of the crystals. And in general, making a crystal diagnosis is really required to say it's gout because hyperuricemia does not equal gout. You can have a high uric acid and never have gout. And there are other kinds of crystals that can cause arthritis, but I'll mention a caveat to that in a minute. So here are the crystals. These are from a tophus. Typically there's a whole lot of crystals in a tophus, not nearly as many in a joint. So up at the top is essentially a dark field. So you can see that the crystals are shiny, right? So they're birefringent. And then at the bottom, we've put in a polarizing crystal that sort of polarizes light one way or the other. And so the yellow crystals are very needle shaped and they shine brightly yellow, and that's characteristic of MSU. I think I have a picture of CPPD. But other crystals have different characteristics, so they're blue in that direction, or they're a different shape, or they're not as strongly birefringent. And so identifying these crystals in a joint or a tophus in a patient with suspected gout is really how you make that diagnosis. Now that said, there are some features on ultrasound that are very specific for gout. They're not sensitive, however. So in this case, we're again looking at the surface of the femur. I showed you that earlier in osteoarthritis, and we see that black layer of cartilage. But now the little arrowheads are pointing to this extra line that's there. That's not bone, that's MSU crystals layering on top of the hyaline cartilage on the femur. And so that is called a double contour sign. If we see that, we can pretty much diagnose gout in the correct clinical circumstance. If we don't see it, we can't say they don't have gout. So you're still sometimes needing to get crystals. But if we're lucky and see something like this, then we can make that diagnosis without having to go and identify crystals. Tophi can be very dramatic. They can be very subtle. So, you know, that little one in the ear you might have completely overlooked. This one you probably would see. Sometimes people will have this really incredible tophus burden, and that leads us down a different treatment pathway. That's not the most common, but we've certainly seen that even in our clinic. On the x-ray, you can see at the index finger MCP, that sort of large erosion that's sort of taking a semicircle of bone out. That's called they call them rat bite or overhanging erosions. They're different than the little fuzzy marginal erosion that we saw in rheumatoid arthritis or some of the changes we saw in some of the other diseases. So sometimes the x-ray can clue you in if maybe for some reason gout wasn't initially on your list. There's also a lot of soft tissue swelling and other tophi in that image as well, which I would show you if my pointer worked, but it doesn't. Other associated factors with gout, so if there's a trauma or some other trigger that can lead to some acute attacks. Alcohol can increase uric acid. That's one of the reasons that we counsel about diet in gout more than some of the other arthritis conditions. Some medications can interfere with how we excrete urate and how our urate is regulated in our body, and so medication list reconciliation can be really important. Aspirin affects gout depending on the dose, so low doses can cause your serum urate to go up, and high doses can cause you to pee the uric acid out. Treatment with allopurinol or febuxostat or anything else to actually lower serum urate and treat it can actually cause acute attacks, because now we're sort of mobilizing all of that uric acid burden that's there and trying to reduce it, but by doing that we can actually trigger attacks. And so while we want to reduce the urate burden, we want to get the uric acid level below 6, for most patients below 5 if they have a large tophus burden, we can use allopurinol or febuxostat for that. For various reasons, allopurinol is usually our first choice. And then if there's a really high burden of disease, there's a lot of tophi, there's a lot of erosions, maybe you can't get the uric acid lower, there's a biologic agent, peguricase, that's used for severe refractory disease that's an infusion. Again, NSAIDs can be used for acute attacks. Colchicine disrupts that inflammatory cascade that I mentioned that's triggered by these crystals being in the joints. You can also use colchicine or NSAIDs as prophylaxis to prevent the attacks that you know you're going to institute when you start lowering the uric acid. If you don't have access to either of those, whether for comorbid conditions or other medications they're on, you can also use corticosteroids for those kinds of things. And this is another one where education is just so important, because if you give somebody a medicine and then they start having gout flare after gout flare, they're not going to want to take that medicine. Clearly that medicine is not working for their gout. So you have to really explain up front that we're going to give you this medicine. It is going to increase your risk for gout flares. We're going to give you this other medicine to limit that until we get your uric acid to goal. And so there's a lot of patient education and sort of back and forth about this up front so that they understand what to expect. Gout is not the only crystal that one can get in a joint. So CPPD, or calcium pyrophosphate, is another type of crystal, which can cause something called pseudo-gout, which can act just like gout, thus the pseudo-gout. Also very commonly coexists with osteoarthritis or impacts osteoarthritic joints. So on the left, we see an x-ray of a knee with really no joint space to speak of, and we can see chondrocalcinosis. So if you look in between the femur and the tibia, there's sort of this extra line there, extra bright stuff, and that stuff is calcium pyrophosphate. We can also see that on ultrasound, so that same view on the femoral condyles, we can see the bright white stuff in the black space where the cartilage should be, and that's CPP crystals sort of infiltrating the cartilage layer. So unlike the urate crystals, which like to sit on top, the CPP crystals like to be inside the cartilage, and we can also see them in the meniscus on the lower image. So important to think about other types of crystals as well. So to summarize, what we've talked about is that arthritis is a wide range of things. It can be inflammatory, less inflammatory, systemic, not systemic, can affect joints or other tissues, can affect joints in different patterns. And so just that word alone doesn't tell us a whole lot. And often I'll say to my patients, you know, there are over 100 kinds of arthritis, because they come in and say, oh, I have arthritis. I'm like, well, let's think about that. There are clinical and radiographic features that help you to define subgroups, which then can help you to understand prognosis and treatment options based on that, and recognizing those characteristics can allow appropriate treatment if you're a rheumatologist, but also appropriate referral. So if you're in primary care and it's a patient with obvious knee osteoarthritis, they might not need to go anywhere. That might be something that you manage. Whereas if they show up with symmetric boggy synovitis of all of their hand and foot joints, they probably need to get to the rheumatologist yesterday so that they can get treatment for their RA. So just sort of understanding the patterns and that there are so many differences can really help to guide therapy. And it looks like that is it.
Thank you, Dr. Nelson. So we have time for a few questions. If anybody has any, feel free to type in the chat box. You're also welcome to unmute yourself and ask your questions that way. So while everybody's thinking, I'll just ask a couple that I've received. So the first one is, why are women more susceptible to getting OA? Is it due to women more often having issues with bone density?
So we don't necessarily know. There certainly are some genetic reasons that happens. There are some other conditions that happen. People have been very interested in estrogen and how that might impact things because typically women will get osteoarthritis in their postmenopausal years. Interestingly, gout also happens postmenopausally in women. So it's likely multifactorial, but it's pretty apparent in most studies that women are at greater risk.
Great, thank you. And I also have another one. So how often does OA affect younger people?
Yeah, so it depends what we mean by younger. So generally not going to see it in kids, but certainly we can see it in adolescents sometimes if people have had very early onset of very severe juvenile forms of arthritis. They can develop secondary OA at a pretty young age. The other situation is post-traumatic OA. So we see, unfortunately, a fair number of ACL injuries and other types of particularly knee injuries that happen in youth sports that then accelerate the development of osteoarthritis, such that if you had a ACL tear when you were 12, you might have knee OA by the time you're 25. And so it is possible to see, it's just not the most common pattern.
And it looks like we have another one. So for AS, when fusing the SI joint to reduce pain or inflammation, will the pain move up the spine like it does with some other back issues?
So it depends. I want to say it depends for all of the questions. Some people only have SI involvement. So they have AS that's isolated to the sacroiliac joints. And if that happens and they fuse, and this is natural fusion, this is not something we do to them, they fuse them themselves through the inflammatory process, then that might be it for them. They may never have another manifestation. Other people already have or will develop involvement anywhere along the spine. So we think a lot about lumbar spine, but you can get it in the cervical spine or the thoracic spine as well. So if they're a person who's going to do that, then certainly they can still continue to have symptoms and may need ongoing therapy for that. But there are isolated SI joint patients who maybe don't need systemic therapy. It's pretty hard to sort out who those people are, but that's kind of one of the patterns that can present.
And we have a question from the chat. So this person would appreciate hearing some more about lupus, just because she has a family member that was diagnosed in her 70s, which, based on her impression, thought it was fairly late in life for such a diagnosis. So if you could kind of talk a little bit more about lupus in that regard.
Yeah, so again, this talk is focused on arthritis, and arthritis is, arthralgia is more common in lupus than arthritis is. So that's why it's not a focus of this particular talk. Lupus has a lot of other manifestations that can present in older age. It is a little uncommon. So typically we think about it in the 20s and 30s, but I've had even rarer, I've had men who presented in their 70s with features of lupus. So really all of these things have a typical pattern, and then they have any other way that they can present. And it's about keeping sort of a open mind and thinking through the kinds of symptoms and test results that you're getting, and sort of working through that. But lupus has many, many manifestations outside of the joints. So it can have oral and nasal ulcers, they can have low cell counts, they can have lots of different autoantibodies. There are lung and cardiovascular complications. There are obviously inflammatory kidney disease that we didn't go into. So it's really a different thing that arthritis is a very small part of.
It's just a question that I have. I believe it was when you were talking about AS and you talked about DMARDs being used as a treatment. And I was just curious as to what DMARDs are, like what type of medications those are.
Oh, so DMARD means disease-modifying anti-rheumatic drug. So that's any condition. And typically when we say DMARD, we're meaning things like methotrexate and oral medicines that have been around for a long time that we know can affect the disease process, in contrast to biologics, which are targeted, often monoclonal antibodies that direct towards specific inflammatory pathways. So DMARDs tend to be a little bit less specific, older types of treatments that can still be very useful, particularly for RA, but they're just a little bit different category.
Great, thank you for explaining. Okay, so I'm not seeing other questions, but what I'm going to do is I'm going to wait another minute or so. We can wait till 10:25 to see if anybody has any other questions. If not, we can go on and give everybody back 5 minutes out of their day. But yeah, just feel free to ask questions by unmuting yourself or typing it in the chat box. Okay, so I'd like to say thank you again, Dr. Nelson, for taking the time to talk with all of us today about arthritis. As a reminder, I'll be sending a follow-up email to everyone in the coming days with a link to access this recording in case you'd like to listen to it again or share it with your colleagues. Thank you again to everybody for attending the talk. I hope everyone has a nice day. Bye.